Yeah. Good morning, everyone. My name is Giáp, and I'm a doctor from Neurology Department of Hanoi Medical University Hospital. And today I have a brief report about LGI1 antibody encephalitis from a case series at our hospital. Now, as we know, limbic system is not rare term, and it is characterized by a subacute onset of concerts or seizures or memory impairment or psychiatric or behavior disorders. And about etiology, limbic encephalitis are usually associated with some antigens. They are divided to two types. The first type is intracellular antigens, such as anti-A2, anti-MA2, which though these antigens are usually related to cancer, so the treatment response and outcome is not good. And the second antigen, the second type of antigens is cell surface antigens. Several years we haven't heard a lot of NMDA encephalitis, but now today I want to mention to another immune encephalitis. It is called LGI1 antibody encephalitis. It is the second most common type of autoimmune encephalitis with really specific characteristic of clinical symptom, investigators, and treatment response. Let's start with a typical case. 33-year-old female patient. She had first symptom with mood and personality changes from April 2022. She did not go to hospital and have no treatment. From 1st to 13th of May 2022, she has new symptom with short-term memory impairment and focal dystonic seizures in her left arm. This kind of seizure is really rapid and short muscle twitches in her arm. So she was admitted to a neurology department in other hospital. At that time, her brain MRI is normal, and her CSF tests were no cell and normal protein concentration. At that time, doctor also did the multiplex viral PCR, tuberculosis PCR, and autoimmune encephalitis antibodies in her CSF, but all the tests were negative. So she was given no special treatment. From 14 to 26th of May 2022, she was transferred to a psychology department with a diagnosis of adjustment disorder with depressed mood. But from 1st of June 2022, she had new symptom with really specific seizure called facial brachial dystonic seizures, and she went to our hospital. The first MOCA is 18 out of 30. Because she had the new symptoms, so we decided to do the brain MRI again. And at that time, the result is we observe changes signal in bilateral hippocampus, and we also do the CSF test again. The CSF was still normal with no sign and normal protein concentration. But we also thought about autoimmune encephalitis because she have a lesion on the limbic system and have memory impairment and seizures. So we decide, so with facial brachial dystonic seizure, so we think about LGI1 antibody encephalitis, and we decided to do autoimmune encephalitis antibodies again, but at that time we do in the serum, and the result is positive. So here is the patient's MRI imaging. We can see the lesions in her bilateral hippocampus and insular lobe. Because limbic encephalitis are usually associated with cancer, so we also do death malignancy screening for the patient, but all result is negative. With really specific imaging on MRI and the positive result with LGI1 antibody, the patient was diagnosed with LGI1 antibody encephalitis, and she was treated with high-dose intravenous methylprednisolone 1 gram in 5 days, followed by a corticosteroid taper. We also use carbamazepine to control her seizure. So after 7 days of treatment, at the time of discharge, patient had complete seizure control with MoCA increase from 18 to 24. And after 1 month follow-up, we observed significant improvement of memory with MoCA of 26 out of 30. So she is one of 8 patients in our series case. So you can see all characteristics of our case in this table. We have 6 female patients and 2 male patients. So about clinical features, patients usually presented to us with 2 notable symptoms. The first one is seizure, especially focal seizure. So we observe 7 of 8 patients have a focal seizure when presented to us, and especially we observe 5 patients have facial brachial dystonic seizure, or it's called FBDS. This kind of seizure is really strong clinical indicator for LGI1 antibody encephalitis. And the second symptom is short-term memory impairment. On brain MRI imaging, we can see the lesion on limbic system, especially in bilateral hippocampus. In our case series, we seen abnormally in bilateral hippocampus in 7 of 8 patients. So you can see that here with LGI1 antibody encephalitis, we need to do the fighting antibody in the serum, because the likelihood of finding antibody in the serum is much higher in CSF. About treatment, LGI1 antibody encephalitis has really high effect, is really good outcome with immunotherapy. All our patients was first-line immunotherapy with high-dose intravenous methylprednisolone, followed by corticosteroid taper. We can combine plasma exchange and other suitable drugs to control seizure. We have 7 of 8 patients showing marked improvement with completed control seizure control and really good recovery of memory function. So about I will say, okay, we have some key points. Is that notable symptom of LGA1 antibody is short-term memory loss and focus seizure, especially FVDS. And to diagnose this type of autoimmune, we need to finding antibodies in the serum than CSF, and the treatment and expected improvement of this kind of autoimmune is quite good. Thank you for your listening.